You'll see more detail. The reason why I think it's important is that if I understand a lot of the questions and issues that go on your website, there's a question about all these different procedures and how they relate to each other, and a picture is worth a million words, and if you can see what's going on here, all the various alphabet soup procedures may make more sense. All right. Also, I don't give formal lectures, so interrupt me at any point and make it informal, please. This is a terrific time. You know, as confusing as it is, there are great options that you have as far as surgical remediation of Fuchs problems, and confusing but wonderful. That's Signe's slide. This is your time to walk. Actually, the films come later.
Cover your children's eyes.
Well, they can move to the back of the room.
All right. This is the progress. Okay, Bruce, thank you for the slide on the left, which is a square Castro-Viejo graft done in what year? 1965. That's still a 2020 cornea. Okay? How someone could do that corneal graft without an operating microscope, just with loops and big sutures, but it works great. Picture on the right is a corneal transplant done a couple of weeks ago, working terrific. Your typical penetrating keratoplasty. PK, I think is the abbreviation used on the slide. Penetrating keratoplasty with all 24 suture bites and all the craftsmanship that goes into that. DLEK, DSEC, whatever it is.
D asterisk K.
Yeah, asterisk, LEK, or whatever it is. That's a deep lamellar transplant. And you can see that it's a whole lot less busy than all of the other surgical options. These are the issues I wanted to hit here if we could, is when to consider a corneal transplant, the different procedures, how they evolved, what to expect, post-operative course, medications, lots of questions that I see that have to do with sutures, astigmatism, and post-operative treatment, and just the very, very uncommon issue of rejection for the Fuchs community. This is important, I guess. You know, a common question, when to consider a corneal transplant? And the answer is two parts. One, I'm visually impaired. Okay? You can't do the stuff that you want to do. Huge, huge factor. But the second part, there's a second clause. It has to be caused by the Fuchs dystrophy. There are any number of folks that we see that come in that have the label of corneal guttata or corneal edema or whatever and are visually impaired, but it turns out to be cataract or some other issue. I can't tell you how many Fuchs problems we've solved with cataract surgery. But the time that you do a transplant for Fuchs is when the cornea is limiting vision and it's due to the cornea. Early morning symptoms, you know, huge clue, okay? If someone is a morning vision person, they're not a Fuchs person, okay? If you get up and you see good in the morning, you don't belong in this room. It's that simple, and that is such a great screening question. And there are folks that come in, I have Fuchs dystrophy, I'm ready for my corneal transplant. How do you see when you first open your eyes in the morning? I see great. We're looking for something else. That's not what it is. And the other issue, in all seriousness, is when to intervene. Usually Fuchs corneas come in pairs. One will lead the other as far as progression is concerned. And if you have one cornea that's moderately affected and the other that's following, there's a rationale to at least have one cornea getting better while the other one is following the progression of Fuchs dystrophy. The whole talk is about lamellar transplants, and I'll call them lamellar, which is your DSEC, DLEK, whatever. Those are your lamellar procedures, and there are penetrating procedures. A penetrating graft is a great option. It's still a miracle. It's a terrific procedure. And there are any number of corneal specialists out there that do penetrating grafts as their primary and only procedure. And it's fine and it's good. And as much interest as there is in the group with the other procedure, it's a fine option. Separate. We'll skip over this slide, but
No. You made the bullet items, now explain it.
a lot of these slides are from a presentation done at the Cornea Society meeting a couple of months ago, and I didn't redo all the slides. But basically, the idea in the newer procedures, you have, and Barry sort of minced his words a little bit, Dr. Edelhauser is the cornea physiologist, and has been, and he is the last word, and he is sitting in your presence. He'll give you all the elegant explanation, but the cornea is basically a watch crystal, all right? And all we do, we don't work on the watch, we work on the watch crystal. And for years and years, we've been doing these procedures in which, when there was one layer of the watch crystal was scratched and didn't work, we replaced the whole thing, okay? And I guess I've been scratching my head since the early 80s when I started doing it. There's just one layer of cells that's wrong, okay? There's one layer that's messed up. Why are you going to replace the whole watch crystal? Well, luckily there are smarter and more creative people in the world than me, and I think Dr. Mellis gets most of the credit in figuring out that you could remove the back stroma of the cornea along with the diseased endothelium and replace it. Okay? I mean, it's seriously creative, difficult surgery, but he figured out how to do it. And that was really a great step, because you could leave most of the watch crystal, most of the cornea intact, and replace the endothelial layer. And that was your DLEK procedure. And basically, Mark Terry was really the one to run with that and perfected the procedure. And you were trading posterior back of the cornea and endothelium for a donor back of the cornea and endothelium. It's the hardest operation an ophthalmologist can do. I mean, after 25 years of doing corneal transplants, doing that operation just made everything else look simple. Absolutely humbling operation. Well, Mellis got smart again and said, maybe we can make it a little easier, because the hardest part of a DLEK procedure is actually removing the back stromal layer of the patient's cornea. It's a very difficult maneuver. And I'll show you pictures of this, and please don't let me run out of time, because the pictures tell a lot more than the words. Basically, Mellis figured out you don't really have to remove the posterior stroma. All you have to do is remove Descemet's and the endothelium. And that's a very easy thing to do. In fact, we do it surgically by mistake sometimes, because it just wants, particularly in a diseased endothelium and thickened Descemet's, it wants to come off. And all you do is very easy. You take one of the hardest maneuvers in all of surgery and transform it into the easiest, and you can just take off Descemet's in the endothelium purely by scraping. Mark Terry's word is stripping. So those that do it this way are known as the strippers. Anyway, the other little analogy that I like to use is that the lamellar procedures are very much like a digital camera. Okay, digital cameras are getting much better, but really the standard is a penetrating graft, which is your fancy Nikon or Canon, single lens reflex camera, where you can have the ultimate resolution. They're getting closer to each other, but there's still no question that the gold standard, as in I need 20/20 or better vision, may be a penetrating procedure. There are times that we still have to do penetrating procedures. In folks that have not had cataract surgery, I can't believe the video is actually going to play. The combination of having your own natural lens, having a short eye, narrow anterior chamber, there's not enough room to do a deep lamellar procedure, and you end up having to do a penetrating procedure. if you could actually see it and stop that, you could see with that slit beam how close the back of this DLEK button is to the iris of the eye. It's a fairly narrow anterior chamber. Why do one of the newer procedures? Okay, why do one of the newer procedures? Number one, it's a one-way deal. If you have a penetrating graft, you have a penetrating graft, you can't go the other way. And if you're starting off with an eye that hasn't had surgery, you might consider one of the newer lamellar procedures, because if it doesn't work to your satisfaction and your surgeon's satisfaction, you can go to a penetrating graft, but you can't go the other way. Okay? It's a very tiny incision. I'll show you in the pictures afterwards what a large incision, a full thickness corneal transplant is, and there are a lot of issues that go along with it. You miss the surface issues with the smaller lamellar procedure. You miss the dryness, you miss the astigmatism, the nearsightedness, the farsightedness. There are a lot of issues that you don't have in order to have something that's optically just about as good as a full thickness corneal transplant. Bruce, this is the thanks to the eye bank picture. It didn't start out this way, but we have had tremendous support from the Georgia Eye Bank in doing our deep lamellar procedures. The logistics include, with the difficulty in preparing a donor for the deep lamellar procedures, we've had to have, like all the surgeons do that are doing this, have 2 corneal donors present. And in doing that, it puts a strain on the eye bank. It shows the eye bank's motivation to help, because with each donor, what we have to do is, and has anyone shown this slide of what's supplied by the eye bank yet? I don't think I've seen that yet. But on your left, that is what the eye bank supplies, and that's a corneal scleral rim. And that's what Dr. Edelhauser told you that Dr. McCary and others had found can be preserved for a week or more in preservative solution. That's what comes from the eye bank that we work with. The key to the lamellar procedures is seen on your right. And I don't know if you can see these tiny slides, but here's the separation of an 8mm cornea button into a back of the cornea endothelial layer and a front of the cornea part that we're going to discard. Okay? So that layer that's being picked up with the surgeon's left hand, if you can see that, is a posterior stromal layer, which is going to be the donor in a deep lamellar type procedure. Evolution of the procedure. Do I have a pointer, by the way? Is there one? Yeah, here it is.
There it is, okay.
Can anyone see that pointer?
Yeah, it should be green.
No. Well, you have David at the screen on Zoom.
Tell us where you point.
All right.
There it is.
This was the original Mella's procedure, okay? And if you could see the size of the incision, it's about yay big. And when Mella's first came out with the deep lamellar procedure, he did not fold the corneal tissue going in. So it had to be put in unfolded. So it was a larger incision. The next huge innovation that Mella's made is he said, well, if you can put it in normal, you can fold the corneal tissue into sort of a half taco and put it in folded. And that's what allows us to do the deep lamellar incisions under through a tinier incision. Dr. Edelhauser is probably getting chest pain when he sees us fold the cornea in half like that, which is endothelium to endothelium. But Dr. Cherry was nice enough to do the studies that showed even after folding the cornea and putting it in, the resultant endothelial cell count is still pretty high. And it offers a lot of advantages. Here you can see it. It's basically that corneal disc that I showed us removing before, folded in half and being put in through a tiny incision. This is what the strippers do. And this simple maneuver is basically just using a very special instrument, which is just a little hypodermic needle, which was designed by our fellows, so we call it a Hoops needle. And this, you just score from the inside Descemet's membrane, and Descemet's membrane and the endothelium just come out. After a corneal transplant, penetrating graft, large graft, surgery should take about 45 minutes. First aid check. Usually there is improvable vision that occurs at about the 3-month point. All right, that's when the surgeon should be trying to get you into the best pair of glasses or make suture adjustments to try to visually rehabilitate the eye with a penetrating traditional graft. 1 to 10 years or longer is when you remove the nylon sutures that hold the cornea in, and you go through, and I think I've read in a lot of the letters, people go through 2 periods of visual rehabilitation after a penetrating graft. The first one is with the sutures in, and then the clock starts again when the sutures come out and all the curvatures change. Glasses, contact lenses are fairly typical for penetrating grafts. Rarely do you have unaided good vision after a traditional corneal transplant. Again, here a little editorial. If you've had a penetrating graft, you have to have extreme vigilance for remaining sutures. If you wake up with an eyelash in your eye and you're a Fuchs patient with a corneal graft, it's not an eyelash. It's a suture. Okay? And it's a good time to call your ophthalmologist and say, I need the suture removed, because the events will go from loose suture to irritation to possible infection, and it can run into a rejection and all sorts of things. So never live with symptoms in a corneal transplant eye. If there's one message from this talk, it should be never live with new symptoms from a corneal transplant eye. Lamellar procedures. When we started out doing these, you know, it was basically trying to build a ship in a bottle. And we were taking the better part of 2 hours to do these procedures. Now with simplifications, I think we've done them in 35 minutes. We found out that with the lamellar procedures, where you use an air bubble to hold the tissue up, it's very valuable to do a 3-hour check and to find out what the eye pressure is and to assure that the tissue is in good position. You expect improving vision in a few weeks, sometimes even in days, but in the first few weeks. And you skip all of the issues of suture, surface, astigmatism, thick eyeglasses, etc. And you see gradually improving vision for 2 or more years after the deep lamellar procedures. This slide's also for you, Signe. If you have a non-compliant patient, it's probably best to do a deep lamellar procedure.
If somebody doesn't follow directions.
And someone who doesn't follow directions. This is a patient that we had from Macon, Gussie, 89 years old. And this was at the point that we passed, you know, what is a better procedure to do in someone that has one eye? Okay? If you asked us 3 years ago, if someone had one eye, they get a penetrating graft, a penetrating graft, or a penetrating graft. And then there was sort of a transition, particularly if you thought someone might be trauma-prone, that you might do a deep lamellar graft. Anyway, Gussie from South Georgia, one-eyed patient. She had surgery in late January 2004 and had very poor count fingers vision. I'm sorry, these are ophthalmology meeting slides. Count fingers vision in the right eye. In 2004, we got a 1-week, I think it was a 1-week visit out of Miss Blue, and she was very happy because her counting fingers vision had improved to 2200 in her only eye. She was happy, supposed to come back in 4 weeks. The last time I was accumulating data, which must have been 2-3 months ago for the meeting, I looked, and we didn't have any more post-operative visits on Miss Gussie. She didn't come to any more appointments. And we said, well, she's 89. We sort of knew what happened. You know, we should have sent a condolence letter and so on and so forth. But just in case, we called. And Miss Gussie was at home, and we said, Miss Gussie, you're about a year late on making your visit. A 2-week visit just isn't quite enough after you have a corneal transplant on your only eye. That doesn't work well. And Miss Gussie said she could see real good, and that she could read her Bible with her magnifier, and she was doing absolutely fine. And she was frankly surprised that we were calling to find out how she was doing. And she's supposed to come back. If you know that you have a Gussie, you probably don't want it, because that would not work with a penetrated graft. That works with a DLEK. We still haven't seen Gussie. She's made many promises to come back, but she has not come back. I'll show you in the pictures, but sutures and astigmatism is a lot of work that we do in patients with penetrating grafts. And for the first year or two, it's removal, adjustment of sutures, prescription of glasses, contact lenses. Whether you're going to be very nearsighted or farsighted after a penetrating graft is always a surprise to both the patient and the doctor, and there are all the issues that you have to deal with. Medications, I think Dr. Lee covered that pretty much. Antibiotic drops for the first week after any kind of corneal transplant, steroid drops afterwards to control inflammation and prevent rejection. Steroid drops, you all know, it's a very knowledgeable group, that you know that over a period of time, steroid drops, pred forte, and related drops will raise eye pressure, and that needs to be monitored. And in those that haven't had cataract surgery, you want to limit the amount of pred forte that you get in order to prevent cataract formation. Rejection is very, very uncommon with Fuchs dystrophy. Fuchs is considered one of the less complicated things that we treat with corneal transplant. It's very, very low risk for immune rejection. Again, redness, irritation, decrease in vision, if you've had a transplanted eye, is not something that you live with. It's at that day, you call your doctor, find out what it is, because if you have a rejection, you've had a 1 in 10 possibility. 9 out of 10 people with Fuchs dystrophy that have a transplant of any kind will never have a rejection episode. But if you do have it, there's a 9 in 10 chance that it'll get better on eye drops. You just need to let us know about it. And eventually, as good as the lamellar procedures are, at some point we're going to figure out how to do this on a cellular level. You don't even need to replace decimase. You just need to biologically re-engineer the cells so they can do right. And once that happens, it'll be an even easier operation. Can we do that? We have time to do some videos? Okay. I said it was unedited.
Is this Jill's video?
What's that?
Is this Jill's video?
No, it's not. Hers, I think I have hers. It should go, shouldn't it? Because we're not going to watch the whole thing. Here we go. This is our view of a cornea during surgery.
This is the graphical part.
Okay, if you don't like it, you can go. This is actually not the graphical part.
No, it's getting there.
It's getting there. Okay. And basically, with a penetrating graft, which this is, we'd like to mark out what's going to be the center part of the cornea. And again, we put these blue marks on because eventually when the cornea is removed, we put on the new one. It guides us to where the suture positions are going to be. And we can actually go through it pretty fast. And this is in preparation for removal. And this will give you a feel for in a penetrating graft. And this is being actually done by our fellow. Okay? We've had the world's best fellow this year, would you say, Barry? Some sensational fellow. And we're removing...
I'm going to mention his name because we have some folks from Utah here.
Right. One of the things we wanted to make sure was our fellow was so good that he moved very far away from us. He's going to be in Salt Lake next year, and he is a fully competent, incredibly competent, nice guy. He's a big gift to Salt Lake. Let's see if we can go a little farther. But what I wanted to show you was, if we can go a little bit farther, here you can really see the corneal tissue in a penetrating graft that's being lifted and removed. It is an exercise in manual dexterity. And if you appreciate the fact that you're trying to create a perfectly round circle and replace it with a perfectly round circle and put it in with sutures that are absolutely symmetrical in their effect, you can see why astigmatism and the irregularities are such a huge issue. Again, very, very careful, because as the cornea is being lifted, you can see right underneath is the iris tissue. And you want to operate on the cornea, but you don't want to operate on anything you don't want to. Let's see. That's with the cornea removed. You can see that it's reflected off to the side. This will give you the anatomy. You're looking right at the iris, and the lens of the eye is right there. Isn't that better than trying to describe it? It should point at that, but it's changing the volume that doesn't exist. Okay.
That's the last thing.
Yeah. We can watch this for, yeah, we'll watch this for a second because I don't know how to move it. Let's see. That's why we edit surgical films just. Let's see. There we go. Let's go back just a little bit. There's the new cornea. And of course, it's slippery on the gel. It keeps on wanting to get away. And you can see it's a manual seamstress exercise.
Wow.
That's the donor cornea?
Okay. Well, that's good. You don't have videos on your resource site, is that correct? Okay.
We can. Well.
Well, you're more than welcome to have it. The first 4 sutures in a corneal transplant are rather guiding in how much astigmatism and how much irregularity you're going to get. The suture used, the 10-0 nylon that we use for these sutures, is smaller in diameter than a human hair. So you can see that we'd be pretty useless without an operating microscope. And we can speed Dr. Phipps through a surgery here. Second suture's in. He's very fast. Third suture's in. Fourth. And you can see how we're trying to get the sutures right on the lines that we've created.
Why are there sometimes more sutures than less? What's the guiding idea?
I think it's an art as well as science, as far as doctors are concerned. It takes at least 16 suture bites to really secure a cornea and make it watertight. And then we end up using a 24-bite continuous suture, and then there are combinations of sutures. And we'll sit in meetings where we really don't have anything better to talk about and argue amongst each other what's the best suturing pattern to use for a corneal transplant.
And what's a running stitch?
That's a great question. Here's a running stitch. Starting a running stitch. Do you see that we're putting in a zigzag? We use the first 4 sutures to anchor it, and now we're just putting in a continuous stitch. Very tedious. Again, let's go. Again, more and more sutures. We're going to go all the way around with 24 bites sutures. More. And that's what it looks like.
What's your last knot called? Those on the postcard. What's your last knot called?
3-1-1. 3 bites. It's a square knot. 3, 1, and then 1. But that's what it looks like. That's actually a beautiful graft, and I believe we can graduate that fellow, can't we? Let's go to the next one here. Stop.
Bonanza.
Barren. There you go. This is a DLEK. This is actually Dr. Terry's film because he can really edit things and do things well, and he puts his name on the film.
Not his first film.
Okay.
Hey, maybe that's mine.
And what I wanted to show you is the part that really makes a DLEK a DLEK. And here is the step. Okay, this is what makes a DLEK a DLEK because you're starting with a slightly larger incision and you are basically splitting the corneal watch crystal into 2 layers. And he has to go across the cornea and to split the cornea into 2 layers because he's going to remove, and still does, the back of the cornea stroma along with Descemet's in the endothelium. Some of you have had DLEKs, some of you have had DSEKs, some of you had PKs. But anyway, he finishes the dissection here, has to cover that entire area. And then, again, the dissection. And let's see. Here he's going to enter the eye. So here he's in the eyeball, and this is the hard part about a DLEK procedure because you're going into the eye, and lots of times there's an eye where people have their own natural lens that can easily be damaged. And you're using scissors inside the eye to remove and cut out that back disc of corneal tissue. It's a very, very difficult maneuver. In those folks that we did, and some of you are in here, that have good vision after this, there are nice little dings on your iris where these scissors were used. The operation still works great, but it technically is a very difficult maneuver. He names...
We've only got about 10 cherry eyes in the room. So.
Okay. Dr. Terry names his instruments after his children. And you saw that those were the Cindy scissors. But Nick Pick and all the other things. But this is how he still does the surgery, and he does it very, very, very well. But you can see this extra maneuver, and I think it'll actually demonstrate what that back disc of cornea looks like that's removed. Right here, actually. There's the disc that's been removed.
That's 2 parts, that's Descemet and the endothelium.
That's posterior, that's stroma, cornea substance plus Descemet's plus endothelium. And Mark's rationale on that, why he still does it, is that he feels that creating a recess in the back is a better place to put the tissue rather than just add it on like you do in a stripping procedure. Okay, last one. This is a stripping procedure, DLEK. And the neat thing about this, you saw the penetrating graft. You're seeing the first and only incision being made. That's all it takes to do this procedure. You wonder why we make these marks on the cornea? Yeah. shows us eventually where to put the graft. This is the stripping, actually. You can see a little instrument stripping the decimes, just decimes and endothelium without any other tissue. And there it is. That's all we've removed. That's just decimes and endothelium. Very easy to do. This is what we do to the donor tissue. And let's just progress along there. We make an incision of known depth. And again, this is usually where I tell the fellow I hate this procedure. Because this is the donor tissue put in an artificial anterior chamber. And we're trying to create a depth, which is about 4/5 of the cornea depth. And manually, we're doing the same thing Dr. Terry did in his patient's eyes, but we're doing this on the donor's eye. Once we've, let's see if we can show that. You can see we go all the way across and separate the cornea into 4/5 of the front part that we're going to throw away and 1/5 of the back part that we're going to keep. We take the corneal tissue there, you put it down, we make it into a 7mm button, you remove it,
Is that a sort of circular knife making a button?
right. You can see that that's going to be the 7mm tissue that we're going to use. Removing it. There's the tissue. Do all that just to get to that tissue. There it is. And here's the cool part. After all that work, we're going to separate the two layers. Okay? And that's the back layer. With a little bit of editing, this will be good, wouldn't it?
Has that been stained?
Say again?
Has that been stained or something?
No. We wish we had a better way to see it. It's unstained. It actually has a little bit of a chemical from the preservative media that it's in that gives it the pink color. There's a back layer. We put the tissue on the cornea unfolded. And the endothelium is facing heaven, towards the sky. And we always say to ourselves, make sure, because you can't tell what side is what just by looking at it. And we're going to fold it into the taco shape, eventually. There it goes. You see we fold it in half. We've grabbed it with a forceps. You can see it's coming from the right, being put in through the tiny incision. And again, this can be the most interesting surgery we do because every eye is a little bit different. And we're just putting the folded tissue inside the eye. And it's hard to see, but it's sitting folded right there. Can you see the tissue?
Yes.
It's right there in folded position. And we're maneuvering it because that's what those marks are for. Because we want to position it folded right where it needs to be, and then we're going to just irrigate and unfold it. And there it is. It's in position, and I believe it's unfolded.
How do you unfold it?
You irrigate, and you just sort of irrigate it, and it just unfurls. There we go. In position. Air bubble. It's just back wallpaper on the cornea, and it's the air bubble that keeps it in place. And we'll finish in 2 seconds, and I'm sorry for going over my time. we go. There's a tissue in place, one suture closure, and we're pretty much done. One suture is a lot easier than 24. That's it. Thank you. We could save the questions for later because
Yeah,
I'm
people are
probably
going to
running
write
over.
them down during lunch.
Okay. Here.
Take them home.
Well, I just want